I'd like to introduce Meanie Kahlon. Meanie is the Vice Dean of Partnerships and Strategy at the new Dell Medical School. And for those of you not from Austin, building a new medical school is very rare, and we're thrilled to have one here because we're growing like a weed and we need new physicians to stay here in Austin. Meanie came from the University of California at San Francisco, worked with the dean of the new medical school there, and I'm sure he scooped her up to come here, as he has at least acknowledged. She graduated from Bryn Mawr and did receive her PhD in neuroscience from UCSF, and when she was out in California, worked with a number of startups with software and technology. So she's definitely got a technical bent, but she's done a great job with partnerships at Dell Medical. And in fact, we were just talking about she recruited a friend of mine in the technology area to come to the Dell Medical School. So she's done a fabulous job getting everything up and running. They're actually up and running as we speak with a brand new class of students. And with that, let me turn it over to Meanie, and she's going to share what's going on in healthcare and how Dell Medical School is taking a little bit different view than the traditional medical schools have been.
Great. Thank you, Debbie. Before I start, I'm just curious, is there a way we can get a sense of how many people are from Austin versus not from Austin on the call? That will help me understand the audience.
Sure.
One here for not.
Most or not.
The vocal not group.
I'm one from Austin.
Yes.
Yeah.
Two from Austin.
Three from Austin.
Okay, so
one from San Antonio.
Okay, close enough.
And, Vicky,
and of course Atlanta.
Okay, so it's a mix is what I'm sort of picking up, but there are quite a few folks from Austin as well.
Mm-hmm.
Great. Wonderful. So thank you for that great introduction, Debbie. And just a few little pieces about myself in addition. I'll just add, because you can use that as we continue this discussion to provoke me. In addition to being a neuroscientist, I would say that being a scientist in general, taking a scientist approach to life is important, not just for me, but for many of the leaders that come here. And you'll see that reflected in some of the things we choose to do. I'm a mother, which is very important to me. I have two beautiful children. And I'm also a self-selected immigrant, is the way I describe it. I grew up in India, and I can remember distinctly a dream of coming to America since I was 10 years old. And so it was very much about the ideal of America, and that informs a lot of what I do as well. And the last is important because one of the reasons, one of the sort of moments which pushed me to move from San Francisco to Austin for the opportunity I'm going to describe here and discuss a bit with you, was a moment where I was actually sitting with Kirk Watson, our state senator here in the Capitol building, talking about the school. And suddenly, in talking to him, I realized in a moment that actually the opportunity here in Austin, it was at the heart of some of what I had hoped to achieve in immigrating to America. It really felt like the kind of blank slate, dream the dream you want to dream and build it up kind of opportunity that, to me at least, as a 10-year-old too, I could, when I thought about America, I thought that was the place where you do things like that. You don't get stuck in sort of the mud of where we are. Rather, you think big and then you figure out how to get there. And Texas is actually a kind of a great match for that. And I've enjoyed this move to Texas. I had no idea what to expect. So all of that has been really great. So I thought I would talk to you all through a series of discussions and a series of maybe discussions between you and me about a set of interrelated topics. So perhaps we can just first start with healthcare is in the topic. So I'd love to begin just by focusing on healthcare, and I encourage you to think of the word healthcare not as one word, healthcare, but as health and the word care. And I'd love to just start hearing from you all, just as a first pass, when you hear those words, what brings a smile to your face and what brings a grimace? What are your reactions? In the balance, I'd love to hear what are your reactions in the spirit of, were you to build something with a blank slate, what would you want to do? But critiques are also necessary and good, so we know where we don't want to go. So I thought I'd just start with that first. Anyone? What about, let me tease you all.
I'm trying to defer, but I'll jump in, Mini. This is
Oh,
Debbie.
great, okay.
What puts a smile on my face is the thought of staying healthy and out of the doctor's office and out of the hospital. So conversely, what puts a grimace on my face is either one of those. Most of us don't particularly like to go to the doctor. And certainly, I've only been in the hospital when I had my kiddo, and it was a good experience, but I only have visions of, frankly, hospitals generally being a bad experience, pain and some suffering and just wanting to get out of there. Confining for sure. So I guess that would be my answer.
Great. Anyone else?
Well, my grimace on hospitals is that I feel like you need to have your own advocate with you, that they're not as competent as you would hope they would be, and they don't, you just don't feel like you're properly taken care of.
Great. Yeah. Anyone
I
else?
have to second what Jamie said. I feel that a recent hospital experience here in Atlanta, having moved from Austin, and I say recent, last couple of years, if it hadn't been for an advocate, it just would not have been a good situation. And taking care of my 89-year-old mother and all the geriatric care that she needs, I find the exact same thing. And there's a lot of work that goes into it, but it doesn't seem to get in the right hand. And that's the grimace. The smile. Oh my gosh. I do think that, we are starting to get better at realizing that we don't always need to go to the emergency room, and that our docs are starting to provide more care. We've got all these, and I'm not just talking about the urgent care facilities, but, my mother fell, and I called the orthopede instead of taking her to the emergency room, and oh my gosh, was that a better experience than having to take this woman to the emergency room. So I do think that we are getting better at that. And that's all I have to say on that.
Great. So on this one, we can move a little bit because I suspect there are lots of folks, at least from my reactions to your comments, I think they're going to resonate. And I'll tell you that I'm with you on the hospitals being a terrible experience. I mean, pretty much seeing a physician for me has been a very negative experience. Debbie might have seen this in a talk I give, but there's a picture of a waiting room that I use, and you look at that picture and you want to run away. You don't want to be there. And that's been pretty much my experience as well. And so, of course, when we go to a clinic or a hospital, we are likely unwell. So perhaps to some extent it may be expected that we don't feel great about it. But I think we would all agree that the kinds of reactions we have are way beyond the fact that, we were sick when we went in. The sort of negative connotations go beyond that. And so that is certainly one of our starting points, that the entire experience of healthcare is just not a very positive one. The other I'll add, and I think, Debbie, you started with this, is the relationship between healthcare and health should be really close, but in fact it's not. Life should be about being healthy. If healthcare is an industry, then the health part of it should be a major focus, but the reality is healthcare is about intervening at a certain point. In addition, it's about intervening in a manner that is incented by the business model that it runs under, right? That's what happens in pretty much any situation. If you incent restaurants to provide better service and food, well, they will provide better service and food. If you don't create those incentives, sometimes you might get good food, but often you may not. And in our healthcare industry, unfortunately, the incentive right now it's not a negative incentive per se, but it's an incentive that's orthogonal to incenting health. So the incentive is what we call fee-for-service, which is we incent the providers of care to do stuff. And doing stuff on you is not the same as achieving impact. Mm-hmm. And so as we think about some of the reasons why the system is deteriorated to, and I don't mean that right now, I'm not just talking about the U.S. system. In general, these are not fun experiences, and some places are better than others. But if you don't incent a better experience, if you don't incent along how does the patient feel at the end of the day, instead, if you incent and pay for doing things, doing a test, doing a surgery, well, then that's what you're going to get, and that's what we have. That also explains some of the larger business underpinnings of healthcare today in the U.S. I think most of you probably know, but it still bears repeating, that our national statistics around cost and outcomes, so cost and what you get for what we pay, are really quite poor. So we pay almost double per capita in healthcare costs as a society than the next highest country, which is Switzerland, which is we pay around $8,500 to about $9,000 per person in healthcare as a society, and in Switzerland it's about $5,000 to $5,500 per person, and then every other country is below that. In addition, our outcomes as a society are really not great. In fact, for most, if you compared us to other developed countries, we are number 11 out of 11, or in another assessment, we are just above Cuba, which pays much less in healthcare dollars. So lots of room to grow, which does not mean, by the way, and I want to be clear about this, it doesn't mean that we don't have areas where we lead. Absolutely we do. We have some wonderful areas where we're providing some great, so for example, in some specific kinds of end-of-life cancer care, the U.S. will lead. There's a whole bunch of other areas where we are leaders. I'm sure that if you took certain income classes in certain cities, you could get some great statistics. So we have many areas where we show we can really lead and do well, but unfortunately as a system, we're not achieving those results. So I'm going to pause here, but I wanted to make first a link between some of the experiences that you're talking about. And for us, in our analysis, we link that to the business model, because we believe the business model is one, not the only, but one of the major underpinnings that then either incents or disincentivizes the behaviors that then influence the kind of care we get. So I wanted to pause to see if there were any questions about that before we moved on.
Well, I'm concerned that there's not more preventative health out there.
Yeah.
Working with physicians, and it seems to be reactive rather than proactive.
Yeah, and so that's a great point. So let's even just first talk about the healthcare system. I want to go beyond the healthcare system in a moment to get back to the question of health that Debbie brought up. But even in the healthcare system, I mentioned that we pay, as a society, we pay so many dollars in healthcare costs, more than even the second highest country. So the Institute of Medicine did an assessment in 2012 that they asked, why are we paying so much extra? What contributes to all of this extra cost? One of those areas was from the healthcare system. When they have preventive opportunities, the healthcare system doesn't use prevention as a tool, and so they calculated the cost of that. It was about $50 billion or so to society. So that's an important piece. It's going to be even more important when we start focusing on health, not just healthcare. But in addition, if you looked at the total that we were spending that was way beyond what we should be, it's about $750 billion to $1 trillion. The bulk of it, almost half, were actually two other categories. One was waste, and the other was inefficiency. So within the healthcare system, there's a bunch of things that needs to be fixed. Prevention is one of those. But in fact, waste and inefficiency make up the lion's share of what we're doing that we should not be doing as we look at getting better outcomes at a better societal cost. And I just want to say that I talk about cost. I'm not just talking about cost from the perspective of just being smart about spending our dollars, but through being smart about how as a society we spend our dollars, we then create more money to spend for other things, which in turn actually does influence health. So if we weren't spending almost 20% of our GDP on healthcare, which is pretty much what we're doing right now, then we have money to spend on primary education. I'm just saying a few things. I'm just randomly throwing things out, not because I've thought through all of the pieces of this, but pre-K, we know education really early in life impacts tons of metrics out in later years of society. So my only point there is to say that there are reasons to focus on cost. Some are it's just better to be smart about how we use our money, but it has implications on the opportunity cost we're losing, right? So if we have more money, we can do more and better things for society. All right, so let's just, so as I said, we think about what I just described was the cost implications for healthcare, but I want to go back to the health question and prevention in a broader setup. So the other piece is that we have a business model for healthcare. It's a flawed business model, but we have a business model for healthcare. We don't really have a business model for health, right? So whenever, even for healthcare, the metrics, even in the best case scenarios, the metrics that hospitals might use or clinics use are all about what they did to us in trying to address some disease and whether we did better. So if you do a surgery, did we do better after the surgery? So even in the best case scenarios, we're talking about healthcare-related metrics and the business model around intervening. But the question that's been raised now by a couple of folks as well, but that's intervening assuming you're already sick and there's already a problem. What about catching it before any of that starts? And that's exactly where, as we started launching this brand new hub of academic medicine, that's where our head went. We thought that we sort of stepped back and looked at academic medical hubs across the country. We've all come from a variety of different, really strong, robust ones. And as we looked at those and we looked at what we'd want to change since we have the opportunity to design something new, one of the big things that came up was that these institutions are really focused on delivering health care. And so a distance has developed between the delivery of health care and even getting better at that versus actually asking, how do we impact health? Because in the end, we want people to be healthy. And so that for us was an important aha moment as we thought about what it is that we wanted to change to this opportunity that we have here. So let me use that as a segue to set the stage a little bit. And for the Austinites, this is going to be old news, but old but important news. So just for everyone else, the real opportunity in Austin came from a couple of things. One is sort of the fact that because of history and politics and a whole bunch of reasons, a university like the University of Texas at Austin, a leading university, did not have a medical school. So that is actually a rare thing today. And actually, although it may have been missed here, it does create an opportunity because it's a strong, robust academic environment that at this stage now is considering starting a new medical school. And for most other such academic institutions, their medical schools are very, very old and are entrenched. So that, in a sense, is an opportunity. But the biggest opportunity was when the community here, the people of the county that Austin sits in, voted to increase their taxes to fund a medical school. Now, the funding from the community is a part of our annual budget right now. Over time, it'll be a smaller and smaller part, a critical part. But the most important thing that did was it kicked us off, and that is the pivotal role this community funding continues to play for us. And in kicking us off, it did another thing. It created a new model for a community-invested medical school. So then, as we looked at that opportunity, and by the way, I came from San Francisco, and Clay, who Debbie mentioned, the dean, and a few of us from there, but now, from all over the country. When we heard about this, we were really stunned, just because it's so out of the ordinary. But in addition, it was a wonderful place to start when it comes to rethinking the role of academic medicine. So I mentioned that in our assessment, if we had to redo things, we thought, well, one of the big problems is that academic medicine is dissociated from the impact on people from health. Well, if the new opportunity to recreate a medical school from scratch, if that opportunity starts with a community investment, that is a perfect setting to then say, well, that medical school for sure should be tied to first community health. And so there, that is actually the seed of some of what distinguishes us in the model that we're building here, both because the community invested in us, but also because we believe that's exactly where academic medicine should go and where we've sort of lost a little bit. This medical school here in Austin is one that is first and foremost going to be focused on demonstrating the value that academic medicine brings by measurably improving health here in Austin and Travis County and Central Texas. And not because Austin and Travis County and Central Texas, is the only place this should happen. It's because the model is one where we believe that if you root in community, then you really get some traction on the major issues. And then that model is one that we disseminate to the rest of the country to influence how other medical schools and academic medicine hubs can evolve and grow. So as we have been describing our goals and articulating them, a major goal for us is how we demonstrate success here in this community, build the lessons out, and then use those to talk to the rest of the country and influence how the country deals with health and healthcare. In addition, we use this community rootedness to focus on health. That influences everything we do, even our education. So if you think about what's innovative about our education of MDs, what's innovative is that, among other things, we are training physician leaders to focus on health. And straight away it means that our physician leaders need to understand that if health is the goal, then physicians are only one small piece of the puzzle. Unlike healthcare, where the physician has been used to being king or queen, right? So that is a big mindset shift to start training the next generation leaders to be team players in a way they've never been before. So that as they see health problems, they ask, I wonder who we need around the table to solve this particular health problem. And if it's a diabetic, then me as a physician with my drugs and my medical knowledge is only one part of the solution. Maybe I'm not even the most important part of the solution. In orthopedics, somebody was just talking about orthopedics. Well, if the problem is that we seem to have a lot of people who think they want a surgeon, is that true? Do we need a surgeon? Intel, as a company, recently started to look at their records and realized that a lot of people were staying away from work because of back pain. And part of what was happening is they all thought they needed a physician. And so they were waiting for several weeks to get to a physician. So Intel put together a program where straight away you could see a physical therapist. There was no wait. And then if you needed more, you were still in line to see a physician. Well, most of the folks saw a physical therapist, felt better, came back to work, and they were not in line for a physician. So that's just one simple example of where if you take the focus away from just a physician and really think about all the kinds of people that can help, you can really benefit the system. So let me pause here because there was a bunch that I just shared with you about the focus on health and how, and then also the rootedness in community and how that influenced the design of this new hub of academic medicine that we're creating here in Austin.
Minnie, I'd like to ask about and this is Debbie, the community goals. Have you gotten to the point of being able to develop those? And if you could give us maybe an example of one or two?
Sure. So we have high-level goals against which now we will begin developing specific initiatives. I have some examples of initiatives, but the higher-level goals are we have a goal that is to measurably improve health in Central Texas, nothing less than that. And so in 5 years, there will be specific areas that the community has helped select that we will move the dial on. And that's really hard. It makes us very nervous when we look at that goal, but without that as a proof point, I think that we would not be demonstrating this new model effectively. In that, currently we are working, just to make that real, we're working on the articulation of a neighborhood health project We got a little bit more funding to seed it from the Michael and Susan Dell Foundation, and we will probably take a smaller neighborhood as a start, and then develop a model where we actually benefit from everyone in the community's ideas about what kinds of issues are the most important, but also solutions. So it's often the case that if you go to social workers and community health workers, nurses, as well as moms and dads in a neighborhood, and you ask them for ideas, not only what the need is, but also ideas that might be really clever ways to address some pressing needs, they have them. They're sitting there. They face life every day in that neighborhood. It's not as if their minds aren't working. In fact, they're creative and they've come up with ideas. They've just never had a place to actually bring those ideas to the forefront. So we will take that approach for one neighborhood as one initiative under the target of measurably improving health. So that's just one example. We'll also take a disease-specific approach. So we haven't decided on the disease because we are working with various community stakeholders to help us identify the need, where the need is the greatest from the perspective of community. That we might take something like hypertension is on that list, for example. And then that might be a cut that's not a geographical cut of the community, but a particular disease cut. And then we will work on measurably improving the statistics on that for this region.
Okay, interesting. So the community is really involved in helping you set these goals, it sounds like.
Absolutely. And so we, our job is to bring some of the statistics to the forefront, let people see some of the data, but then to hear from folks what is important to them. Now, obviously, it's a very tricky area. Who's the them, who's the community? All those questions come up. But so, for example, our Department of Population Health, which is where, which is what will lead a lot of these community efforts. Which, by the way, is a regular medical school does not usually have a Department of Population Health. So this is a very novel thing. And we have a wonderful person who leads it. He was the CEO of the Regenstrief Institute in Indiana. And where really he looked at Indiana-wide health and actually did a lot around leveraging data to improve health across the hospital system in Indiana. So firstly, the department itself has been set up so that it can address these regional health goals that are important to us. And then that department, as a first step in recognizing that it was going to be critical for community input, has created a community strategy team, where they took applications from the broader community here to join. I think it's a 6 to 8 member team. Every year, a strategy group will change. Most people represent various, usually mostly underrepresented voices in the community, so they have a way to make sure that they are heard. And so that group is then helping to advise on what does it mean to listen to the community, so we don't just assume that we know the answers.
Mm-hmm. Minnie, what is being done to work in the schools to educate children and parents about healthy food?
Oh, what a great question, and one I'm passionate about with my little kids. Well, there's a couple of things. So first, and this is first sort of a mea culpa. So we want to do so much. I individually want to do so much, and I'll tell you that, frankly, we have had to be really disciplined about where we dive in and do projects ourselves versus where we enable others. So that's my setup to say when it comes to a lot of the work that we want to do, for example, with the AISD, the Austin Independent School District, we're talking to them and we're going to work with them. And in the end, our work with them is going to be to influence them and to be experts available to them and to encourage them to create models within their school system to influence healthier eating, et cetera. But in addition, I'll tell you some specific, it absolutely intersects with the clinical flow. So our pediatrics chair, Steve Abrams, has already initiated an approach where when kids come in for any pediatric appointments, they're given a food security assessment, so that straight away we're trying to understand, what does this child get to eat? Does the child get enough to eat? And then we use that to inform the, sort of the prescription. Right? And the prescription need not be drugs. The prescription could be many different things. That we're trying to do an assessment of where a child sits in terms of the kinds of foods they get access to, and then the kinds of foods they eat right from the beginning of care. Nutrition, now on the educational side for our physicians, so one of the big problems that I'm sure you've seen in your own interaction with physicians is that food is such an important influencer of health, yet physicians are not trained in it at all. And so it's a strange sort of blind spot. So we are, in our own training of physicians, nutrition as well as behavior and lifestyle ends up being a big part of the curriculum. They'll never be the be-all and end-all expert in it, and that's okay because there are others that are experts. But they are being taught enough that as these issues come up, they understand, oh, I should go to a nutritionist. Oh, I should go to this person, and bring them into the team that then will help with the particular patient that they're talking to. So on the clinical side, we are trying to integrate notions of food access, nutrition at the point of care in our new models. As we train future physicians, we're making sure that they understand these issues enough to recognize symptoms and then to bring in the relevant experts if necessary, and then that's novel. And then we are working with regional stakeholders, such as the school districts, but several others as well, to start influencing the various pieces that will ensure that our kids eat better.
Any other questions right now?
All right. So then let's, I wanted to just quickly spend a few minutes. Debbie, how long do we have? I just want to modulate.
Well,
since
we're taking questions as we go, we could probably go till about 1:50 or 55.
Okay,
We'd like
great.
to save about 5 minutes at the end of the call for us.
Great.
So another 20 minutes.
Okay, so what I thought I'd do is, one of the things I want to close on is just a reminder that because of the community vote and because of the way this particular medical school got birthed, we have a lot more community involvement from the start. And so we're very fortunate in this model here that we're already starting with a lot of goodwill and a lot of partners that otherwise we would have to work very hard to bring to the table. In this case, we don't have to. And so with the help of all of these partners, we really are creating the city as a laboratory for the best things in health. That's our vision. And the one point I'll leave you with that is that for healthcare, it's a very complex system. And so to think that you can change a clinic or a hospital and somehow that is going to have an impact, I think that's naive. We actually have to usually work with multiple nodes in the system to actually make an impact in healthcare. One of the biggest areas that we're going to have to impact and we're working on right now is as I mentioned, the business of healthcare. And so if payers, the people that end up paying the bills, which are mostly insurance companies, sometimes they're large self-insured employers, if payers keep paying for people to do things, then we're not going to be able to move the dial very much. So for us, as we think about changing the healthcare system to focus more on wellness and health, but also to change it just on doing better in terms of clinical care, a lot of our work goes into thinking about the economics and actually influencing the various nodes of the system, especially the payers. So what does that mean in real life? It means several things. One is we look for which payers are most able to and most interested in being innovative and changing how they pay. Self-insured employers are a major area because they're a rare place in the system where they actually feel the impact. If their employees are sick, they feel the impact. The employees don't come into work. It also costs their system, and they feel it straight away. In the rest of the healthcare system, it's actually an odd. We've sort of ended up with the system in an odd place where, patients, if you're insured, you don't actually feel the impact of the massive amounts we're spending in healthcare. And so I know what my premium is, and I do know when my premium rises, as it's been doing, but it's not to the extent of how things are really rising across the country. Physicians don't know what things cost, so they're going to prescribe things, and mostly they have no idea what they're prescribing in terms of cost. So they're dissociated from the cost that's being borne by society. Hospitals don't care. They're doing fine with the old system. I don't mean to say anything other than even well-meaning hospitals It's just the economics are such that they are doing fine right now. So unless you push them, they don't have a reason to change per se. So we have a strange system where no one particular node is incentivized to actually change the way we deliver health and care. So a lot of the work we're doing is to influence that. So we're working with the most innovative employers. We are also creating new kinds of payers, and in Austin we're able to do that. We're able to take our public health authority and there's a private payer here that actually ends up contributing quite a bit to charity care. But charity care is very irrational. Charity care usually means you open the door of a hospital and whoever comes in, we deal with within a hospital, which is an extremely expensive and also non-optimal way to deal with people when they are sick. So we're working with them on a very creative way to leverage the dollars that the private payer is spending in any case, but to do it in a much smarter way, together in coordination with the public payer. So that's a critical example of what we're doing. And then in other cases where we already have leaders here that are renowned for being the most creative in responding to new payment models. And so Medicare, it's a very hard thing to say in Texas, but it's the truth that today Medicare is one of the most innovative payers. Now that may not be, it's not necessarily about Medicare being up ahead of everyone else. It's just that no one else, no private payer, no commercial insurance is actually being that creative. So Medicare has some pretty aggressive targets of changing the way they pay so that they pay more for value. And just to make it real, one of the biggest changes in healthcare in the country recently has been a new model of payment that and Medicare is providing now to hospitals for knee and hip replacement. So previously, Medicare as an insurance company would pay for the surgery, right? So they would have some metrics about how well you do right after surgery. But now they are going to be paying hospitals, but they're going to be paying them more or less depending upon how well you do as a patient 3 months after your surgery. And if you just think about it for a moment, that's radical. And we know it's radical because, as I said, we have a lot of experts in this area. So our chair of surgery is a leading orthopedic surgeon who's actually influenced care protocols across the country. And for the first time, we have hospitals coming to us, knocking on our door, going, can you help us? We need to actually make sure our patients do well at home. And I laugh, and it's sad, though, but the reality is that until this moment, their business did not depend upon how well you did at home. Their business depended upon how well you did right after the surgery. And in fact, the biggest problems often arise if you look at knee and hip replacements. It's actually the greatest variability comes based on what happens to a patient once they get home, whether they're looked after there, whether they have the right support systems. And so now hospitals are paying attention to it, and that's because the payment model has changed to incent them to do that. So I'm going to pause briefly here before the last little bit, but I just wanted to share how critical, at least in our analysis, how critical it is to think through how the payers are actually paying for things, so that ends up having huge systemic effects in healthcare.
I'm just glad to hear there is some creativity on that front, because I've always thought a lot of the barrier had to do with the payers. So
it is. I mean, it's when we think about the fact that no one is truly incentivized to change the dynamic in any significant way, you would think that a payer would, but even the payers, the insurance companies, they work on margins. And they have everyone's trying to do some smaller things, but as a taxpayer, if you looked back and you step back and as a member of society, I don't think anyone would say that there's significant innovation in a way that the industry really requires. So the Medicare example is right now the most extreme. So that ends up being a big deal, sort of how we respond to that. So I thought maybe I want to end actually to go back to what academic medicine is, and I want to make sure that I leave you with an understanding of what our business is really, because a medical school is quite unlike any other school at a university. All schools, of course, have business models, but we really are running a business that has multiple different revenue streams. So the university I came from, UCSF, just as an example, it's primarily, you could think of it just as a medical school because it was primarily a medical professional school. It doesn't have an undergraduate college. So it's a $4 billion entity. $2 billion of that entity comes from the clinical enterprise. So medical schools run major hospitals, clinics, they hire physicians. They basically run a business that delivers care. And so the word school is a little bit distracting because one always just thinks about the MD class. And they are a very important part of what we're trying to do to change the world. But the reality is it's a business where 50 to 80% of the revenue is going to come from the running of a clinical operation. So as you think about medical schools, keep that in mind. Mm-hmm. Going back to the UCSF example, another 25% of revenue came from research. UCSF happened to be the leader in getting NIH grants, so they got a lot of money in research. They were an active and powerful research house. And then the last 25% is a smorgasbord of other revenue sources, a little bit of state and very little bit of tuition. Tuition plays a very small role in the finances of a medical school. So I say that because I wanted to share some of the structural reasons why we think we can move the dial here in ways that can't be moved other places. And it will also hopefully raise questions for you all as you look at the academic institutions in your own regions. So because of the way it's structured, what happens is, so the clinical enterprise sort of has grown for academic medical institutions. They have hospitals, they deliver care. And guess what model those institutions are using? Well, they're using the model any other business, clinical business would be using, which is they are paid in a fee-for-service way to deliver care. So it's good care, but they're still paid with the same incentives that any other private or other hospital system would receive. And a lot of the revenue that's coming into these organizations comes through that arm. So what happens if you really want to fundamentally change things around? So I'll give you a real example. At UCSF, through a program we had set up before we came here, the various physicians and clinical leaders, the academic clinical leaders, were looking at ways to improve care for patients while reducing costs for society, really dealing with that waste and inefficiency piece that I told you about from the IOM report. And out of many ideas, the idea that sort of bubbled to the top and that everyone agreed would be really a great one was to reduce imaging. So imaging is an area that is overplayed a lot across the board. It's certainly in this country. And so for most neurologists, there are many, many cases where the standard is to give a CAT and an MRI scan together where you only really need one and not the other, just as one example. And every test you do has a very discrete probability of harm. Sometimes it's low, sometimes it's high, but every test is not without its probability for harm in and of itself as a test. So generally speaking, you don't want to do something unless you really, unless you believe it needs to get done. Anyway, this threw a bunch of experts. So the expertise is all there, and they said this is what we should be doing. We really need to create a way where we don't do these unnecessary imaging tests. Well, this is, UCSF is a great institution, but as it bubbled up, that idea was squashed. And it was squashed because there was no way that the institution as it stood then could accept that, because radiology, the department that does the testing, makes huge margins on imaging. And those margins are going where? Those margins for a place like any academic medical center, they're not going, it's not, this is not a shareholder organization, it's going to subsidize the medical school. So the medical school and its research organization, all societal goods, are subsidized heavily by the clinical enterprise that usually goes hand in hand with an academic medical center. And as a result, the incentives are completely not there for that whole clinical enterprise to truly change. They cannot change. They are sort of, in a way, somebody used the term addicted, right? The clinical enterprise arm of a medical school is addicted to revenue coming from the existing status quo system. So that tells you a little bit about why, so for many of us, that underlies why we chose to come to a blank slate opportunity. Because even though we could do some things at the edges, we were never going to be able to create large-scale change because the existing organizations were trapped within a particular revenue model. So in coming here, one of the most interesting things we're doing and the most challenging and frankly risky is changing the business model of how we make enough money to survive. And that's going to be one of the most interesting and challenging things that we're going to be doing in addition to a range of others. But I think until people realize the business model, and where revenue needs to come in and the scale of revenue we need, I think that part gets forgotten because you think about state funding and tuition and things like that as actually the sources of revenue, where for us, those are always going to be pretty small pieces of the bigger puzzle. So sorry, that was a lot, but maybe this is a good time to pause to get questions on that, and then maybe at this point, any remaining questions more broadly.
Yep. Questions, anybody?
Well, there's a lot of press these days also about inflated prescription costs, and that's part of the the model as well. And just wondering how that plays into this as well.
Yeah, and so the inflated prescription costs. And there's several pieces of that. One is just the fact that drug prices are too high. So in the Institute of Medicine report, that was also a piece of it. They could attribute some of the excess that we were paying in healthcare to prescription drug prices being too high. And then there's a whole discussion around, both the pharma industry's role in that, as well as the ability to negotiate or not negotiate by major insurers, and so there's a lot of literature right now on looking at the various drivers of high drug prices. But then the second part of that is the propensity to prescribe, and so that comes back to sort of the fee for service. Now it's not as if, some of the controversy around big industry's influence on the practice of medicine has been around how companies market it to physicians, and I think most thoughtful physicians will agree that they may disagree about where the status today and whether we've gone overboard or not, but I think they'll all agree that there certainly was a period of time where it just went nuts in terms of the direct influence that, for example, sales reps had on physicians, influencing why a physician was prescribing. And it doesn't have to be conscious. This is not because someone said, I'm going to be a bad person and prescribe things that this company told me to prescribe. It doesn't have to be. You just have to have enough, of one group's prescriptions exposed to you that, implicit bias is a real thing, and you might tend to prescribe more of X or Y. So that was a real problem. It's sort of gotten better over time, I think, but it's still an area we need to look at. But yeah, the tendency to fix things with drugs is going to be a big thing that we need to address as we look at better models.
Other questions for Meany? Meany, most of us have either kids or some of us have grandkids. You mentioned being a mother. Is there any wisdom you can tell us about watching out for our own family as it regards health care?
All right, so this is very much me and not Dell Medical School.
Yes.
But yeah, I'll just share my own approach. I joke about it, but it's true. I have to tell you that medicine was the one field that I never ever wanted to get into. I've done a lot of different things in my life. I was almost going to become an investment banker. That was my first job offer was from Bear Stearns in the days when Bear Stearns was a thing. I've done performance art in New York. I worked in the tech industry. I've been a neuroscientist. Across the board. But the one thing I never wanted to do was go into medicine, and partly because I was skeptical about it, and so that's influenced my approach. I'm very cautious. Even with my kids, I don't give medication unless their temperature is really, really high. And by the way, I'll tell you that Bill Tierney, who chairs our population health department, I just let him know that a child of mine was sick, and he wrote me this impassioned plea to not give medication certainly until their temperature was 103 and above. And, so I don't say this as any specific advice, but just to say that there are most of the thoughtful people that are in my world would really focus on things, really mundane sounding things like rest and water, and liquids. It sounds so run of the mill, but superbly educated physician leaders that I'm around basically advise a lot of the common sense stuff like taking care of yourself, exercising regularly, letting your kids rest or your grandkids rest when they're sick, and watching them, but not jumping the gun on interfering with the body's own mechanisms. So, I mean, that's sort of the approach that I take as much as possible.
Sounds good. Like back to the basics, huh?
For me, that's a big piece. Now, that doesn't mean we have advanced tremendously in medicine, and so we must. I mean, I've been at institutions, and this institution will be one of these as well, that is really pushing the boundaries of what medicine can do. But I think the key is to figure out when and where we use technology, and I consider medicine a technology, when and where we use technologies to really improve ourselves and not to overdo it.
Super. Anybody else?
Amy, what's your opinion of the new technology of the call in or go FaceTime with a doctor and get a medicine or a little advice or whatever they're giving?
Yeah. You know, I'm going to reframe that to say that our interactions with the physician need to change, period. And that's a cornerstone of what we're trying to do here. So the first thing is that it would be great if your time with the physician was meaningful. Firstly, it was not a 5-minute, you run in, you run out, and that's it. And it's not good for the physician, and it's not good for you. And so you want to, develop a relationship with the physician where the physician is asking questions where they're practicing at the top of their license. That's the way we talk about it, right? So if all they're doing is reading a blood pressure reading and telling you to up your prescription or bring it down, you shouldn't have gone in to see them. Because firstly, the physician need not do that. So the reason I'm giving you this response to the video conferencing thing with physicians is I would say remote access to various kinds of providers in the healthcare system would be tremendously useful and efficient for all of us. Does that remote conversation have to be with the physician? I don't know. It's usually, if it's remote and if it's quick, it's usually something that's much more transactional and tactical. And we think that there are many roles that exist today and that could be new kinds of roles. Pharmacists are great, just as one example. There are many things one can do through a pharmacist. And absolutely, if you can help not coming in, driving, parking, going in and coming out for a transactional exercise where, let's say, you have a wireless blood pressure reader, it's gone off several times. There are really good algorithms to say, yes, something's a little off, you need to adjust your prescription. You really don't need a physician for that. That could be done with a pharmacist, and if necessary, you could video conference with them. But the physician conversation then should be elevated so that they're practicing at the top of their license, where now you're talking to them not for 5 minutes in and out, while, by the way, you might have waited 45 minutes in the waiting room for that 5 minute with the physician. Instead, you go meet them, and it's, a good half an hour. Maybe physicians, you ask physicians, they want an hour with their patients if you really ask them. And it just happens once in a while, but they're really probing and trying to understand what's happening with you. What are some of the comorbidities you're showing? What are some of the signals which, if they don't really bring it out in the conversation, you might miss? That's really where you want your physician conversation. And I say that because then in that model, you probably do want to go see your physician, but then that's the once a year, right? That's the once a year. You're sitting with them. Maybe it's a little bit more frequent. So there's lots to be explored in using modern technology to make communication more efficient. But in my mind, it's also tied to the role of various providers and what we want from different kinds of providers. And the one thing we shouldn't miss in all of this is the benefits of building a relationship with a good physician and spending time with them in a way that reveals things that no tools can reveal, right? So really benefiting from physicians in the way that they were really trained for.
Interesting. Thank you. Very interesting. I've exceeded the goal that I set by a couple minutes already. So I guess we should cut it off unless somebody really has a burning question. I want to thank Mini very much for taking her time. I know you guys are swamped down there. It's the beginning of the year for your new med class, and thank you so much for sharing some of what's going on the cutting edge of medicine with us today.
Great. Well, thank you so much for having me.
Okay. Thanks so much.
Thank you.
I'm off.